So, case, I picked a case that we didn't do too well. So this is a little bit embarrassing for our practice, but I think the case gives us a lot to talk about, and maybe we sort of calibrate our practice so that, you know, big names like Stanford or Mayo or WashU, bad stuff still happens. So with that caveat, this is very rare exception. So this is one of my favorite patients. He's such a nice guy, and you know, bad things happen to nice guys. October 2015, he was 65 years old. He presented with vague lower chest and upper abdominal discomfort. The patient was known to have hepatitis C. About 10 years before, he was attempted to be treated. And he had no response, not whatsoever, to pegylated interferon ribavirin, so he was a non-responder, stopped after a month. However, he had no symptoms of hepatitis C or cirrhosis. He was just doing fine, felt something, and he went to the ER. No other comorbidity, and they happened to have a CT scan. And this is what they found. So you see pretty good sized lesion. And if you look at on the sagittal, it's sort of a bulging outside the liver. So I'm sure you see this not too infrequently. So alarming situation. So the radiology report says there was one HCC lesion, 4.5 times 3.9 times 3.7 centimeters, LPTN 5B, meaning that he had enhancement, had a washout, he had a pseudocapsule. So this is HCC. He also had cirrhotic changes. There was no portal vein clots, had non-specific lymphadenopathy, but no definite metastatic disease in his gallstones. His labs, his bilirubin was 0.6, AST and ALT were elevated as expected for hepatitis C patient. Alkaline phosphatase is mildly elevated, creatinine was normal, albumin was okay, platelets 46. Alpha-fetoprotein was normal, genotype 1B, lowish viral load. Now, with all this data, what should you do? Endoscopy. Liver transplant, move towards liver transplantation. Why, for the benefit of younger folks, why would you do an endoscopy?
Because, she had low plaquets, but she had also virus C. So I don't know if the low plaquet count is for albumin or a portal hypertension. So we have to check that with an endoscopy. And if she had viruses, well, she had about 10 of portal hypertension gradient.
Then we shouldn't do surgery. That's why you're talking about.
We have to decide that she has to
No
do
resection.
surgery or
Any other comment at this point? Okay. So the patient was presented at the tumor board. The patient was referred to hepatobiliary surgery and was proposed for resect. And we didn't do what you would have done. So what happened was there was no hepatology representation that day in the tumor board. And the surgeons dominated the discussion. This guy has no hepatic decompensation, one lesion dangling on the surface of the liver. You were just go in and chop it out. That's the decision that was made. Yes?
No, the platelet count to me,
Uh-huh.
I think that was it known to the surgeons, because I think the surgeons worry about that. The platelets at 46, well, you know, we have to wonder if this is portal hypertension, even if you don't see it, right?
Yes. Yes.
On the next time, you can see this link is large. So I think that is one of the reasons that we should have done
And this patient is most likely a transplant candidate because he has portal hypertension.
Yes. I agree with that. Linda, did you? Okay. Okay. Yes. And I got it here.
Yeah, okay.
So that was not a good decision, right? Then one of the surgeons had transplant sort of involvement, like halfway. So he felt bad, and so he said, maybe you should refer this patient for transplant. So he came to our transplant clinic. We felt he met the Milan criteria, and we accepted him on the list. However, the patient didn't want a transplant. And we couldn't win the patient over that transplant is a better option. So the patient underwent resection, had segmentectomy number 3, which was where the tumor was. The pathology showed moderately differentiated tumor. He had a focal lymphovascular invasion. His surrounding liver had grade 2 inflammation, stage 4 fibrosis. Nothing else to report. So lymph nodes were picked up and they were normal. So, okay so far. Any comments?
In tumors that size with portal hypertension, tumors of that size in patients with portal hypertension and cirrhosis, we do uniformly transplant those guys. We've had several patients in which they decided to go for TACE, and after TACE they have a complete response to TACE, which is not expected necessarily. It's more like it's not a curative treatment, but they had a complete response. Now they are a complete response and they say, you know what, I don't want a transplant. I want to go now for years and see what happened. Mm-hmm. You test me in 6 months and then 6 months later, and I do follow patients that after they did very well, we continue their follow-up, and as long as they don't have a recurrence, we don't retransplant them. I do have also patients like this that focal lymphovascular invasion, you're only waiting for the second tumor to come out, and then you're just keep them listed, and eventually you transplant them. So,
Hugo?
I'm not presenting a contrarian view, but I think that a 65-year-old gentleman, as good as he is for transplantation at this point, probably the process that Mauricio described would unfold over 3 to maybe 4 years, if we're lucky, if he doesn't have a rapid recurrence. I think that patient may get to be a little too old for many transplant centers to consider. I mean, we're very aggressive, but in some centers they limit people beyond the age of 70 or 65. So he's kind of marginal in the age range. The other part is what was the plan to do after the resection? What to do with Hep C, right? That's still part of the equation. And I think a lot of my colleagues will still harbor this fear that after you resect, now you're treating an HCC that has focal lymphovascular invasion. I don't know, until we know the data, I think that's still a concern. So.
Well, the patient didn't want to get a transplant.
Correct.
That's a very important thing. I mean, he said, I don't want a transplant. So without him wanting to get a transplant, you are pretty much limited to continue his follow-up at this point, and you can potentially give him any other form of treatment, but it will be very difficult to choose any form of treatment at this point. So if this guy goes without any recurrence, maybe the chances are not big, but that's what you should do.
That was a question that I was going to pose. So what do you think about that? So let me just set it up. So you have this patient who had relatively large tumor, and I haven't seen a patient with 5 centimeter tumor completely eliminated with TACE and going for years without recurring. So that scenario is not very likely. Lymphovascular invasion makes you nervous, right? And then, for sure, we're going to treat him for hepatitis C. So we're at a juncture where the tumor is out, the surgery is done. Can we do something based on this histology? And sorafenib question may come here, may come up here. And any of you know, Linda, were you going to comment?
I will give it to the patient. I will. I would.
Well, maybe at this point, I will think that HCV treatment and afterwards maybe on a trial to lie for adjuvancy, maybe.
So I didn't make slides. So there was a recent meta-analysis of using sorafenib as an adjuvant therapy after curative resection. And there were 4 studies that the study summarized, the meta-analysis summarized. And they were all from China. And 2 were trials, the other were observational studies. And the summary hazard ratio was like 0.8. And was like very, barely made statistical significance. But the comment that they made in the discussion for this specific scenario is that people with lymphovascular invasion, sorafenib unfortunately doesn't seem to help. So it's the sort of a better behaving tumors that may benefit from adjuvant sorafenib, but not the sort of the bad tumors that are destined to behave badly. So that's the current status of literature, but I had exactly the same question as you raised. So that was that. And all hell broke loose. The reason why patients with portal hypertension should not have resection is this. Patient developed significant ascites, persistent hyponatremia, and the surgeons first tried to fluid resuscitate, and it didn't work. So they decided to fluid restrict, and it didn't work. And they even tried a course of tolvaptan to manage his hyponatremia.
Never works.
And then, they described patient continued to have ascites, persistent drained from the incision, paracentesis was not successful. So it's a nightmare. And the patient developed confusion and delirium, started on lactulose and rifaximin. He was not eating, so he was being given a tube feed, had trouble with maintaining the tube feed, and then over time his blood sugar started to go up, and he ended up in insulin, and then oral hypoglycemic. Problem after problem after problem.
You know what the main problem was in that case? Surgeons, as always.
They are a problem if they don't take into account hepatologists.
So now, with all the problems, he comes back to my clinic. He had persistent ascites. We had to arrange regular paracentesis, and then he developed huge incisional hernia, as you can imagine, from the recent surgery and huge amount of ascites, sarcopenia. His lab, fortunately, wasn't so horrible. As you can see here, sodium of 130, bilirubin was okay, albumin was still very low. So we did a repeat CT scan. It showed no evidence of recurrence, but he developed non-obstructing left portal vein thrombosis, which is thought to be surgical rather than tumor-related. So what do you do? His MELD is low, right? His bilirubin is 0.5. So his MELD is basically 8. How about tips? Would you do tips? Yes.
Or maybe what about enoxaparin for the portal thrombosis?
Could be considered. It's not mutually exclusive. That was my second question. Anti-Hep C therapy. What regimen? He was treated with lead salt. So our thinking was that he's still recovering from surgery. So instead of jumping into tips, he has precarious liver function. Let's treat him for hepatitis C, and perhaps his liver will wake up, and we can buy some time and help him. So he was treated and he achieved SVR. Okay? I'm sorry?
He got an SVR.
He had an SVR.
Yeah. No, after that. I'm meaning after that.
So, so the timeline is he was diagnosed late 2015. He had the surgery in early part of 2016, and he had the, trouble recovering, and we had insurance requirement and such. So he was treated started middle part of 2016, and he was finished around December of 2016. And I forget what the next slide is. Okay, this is coming, but he still had a lot of problems with the site. It didn't, his liver didn't improve as quickly as I had hoped, but eventually it did. So he had a year of hell of going through paracentesis every 2 weeks. And towards the end of the treatment, his incisional hernia ruptured. Not big way, but it leaked. And we had to intensify the paracentesis. Eventually it healed. So it was a very precarious, but he eventually did get better. His ascites is now manageable. His ascites is gone. He still has huge incisional hernia. So his quality of life has improved. His encephalopathy is good. His lab has improved. So as Linda anticipated, we are better. But now, summer of 2017, he's got 5 sub-centimeter lesions with washout, but no pseudocapsule. So this is not quite 5B, it is called Lyrite 4.
Hurricane is approaching.
Yes. So this is an example. I couldn't get rid of this radiologist mark, but there was a 9.1 millimeter lesion. There's another lesion. Then there were 5 of them in total. So all about 1 centimeter or less. What do you recommend?
I mean, I still believe that he had a histology that was very worrisome. I think that, I mean, fortunately, he survived the complications of surgery. He is a high risk for recurrence. He seems to be like he is moving towards recurrence, maybe. I still believe that I will work on the patient to try to convince him for a transplant.
No metastasis at this point? Lung
That we know
metastasis,
of,
bone
correct.
metastasis, no?
His chest is fine, bones can fine.
Is he producing alpha fetoprotein or no?
I never did. The peak was 14.
The lessons are under 1 centimeter, right? 5 lesions. Less than 1 centimeter. So you can confirm that obviously it's supposed to, or it seems to be a recurrence, but you have to confirm the results by ultrasound 3 months later, or well, it seems, or it's obviously that it's recurrence, but less than 1 centimeter.
What do you do? Do you dare to transplant these patients? What do you do? I mean, I was amazed that you apologized for presenting this case. We see these cases every day. We have many cases like this because they do things before asking, and they come. I have a patient just like that now, and you know, and the time has gone by, and you cannot transplant them. But in this patient is, do you dare to transplant him, and what
I
are you
think
going
Hugo
to do
may have an
after?
answer.
You know, I think that we would probably put this patient on the list. There's no harm in waiting. It's possible to make sure that the natural behavior, I mean, this is not confirmed HCC. We could biopsy and confirm the diagnosis of HCC. They're reachable. It's very likely that it is. It's just not radiologically confirmed. So there's no harm in putting this guy on the list and then awaiting a behavior to decide when you transplant. I think the chances are pretty good that this is recurrence.
And I will add to that because I would just try to think more. This is an LI-RADS 3. Washout, no capsule. Well, I mean, I don't know, they're still small, right? LI-RADS easily 4, 3 to 4. But these are not lesions that were there before.
Correct.
That's right.
So now we have lesions that are suspicious. This is HCC. I mean, how will not be HCC if these lesions were not there before and now they are there? So this is HCC. I don't think we need to do any extra confirmatory test. I think that we should go ahead and proceed. Now, I will not accept that someone will say that this is outside Milan. If
No,
someone said that
right.
these are 5 lesions, I don't care. I think that this patient will still be a good candidate for transplant.
I agree with you. The thing is, the risk that it has for relapse. The other question would be, any protocol with the monoclonal antibodies that are being over there for liver cancer?
You know,
Not in this situation.
I have to agree that this is HCC. I didn't say otherwise, but I would say that you know, you don't have, I mean, if you list this patient right now, you can't give him exception points. So you can put him on the list. That gives you the luxury of not having the patient come up for transplants very quickly and observe what happens. And I think that if you choose to treat him, to give him local regional therapy, I would insist that this guy be biopsied, because you know, you're going to be doing aggressive therapy on this man, and I think it doesn't hurt anything to know and confirm that this is HCC, to know what you're treating. And then I think that in this patient population, it's a little scary that they're going to have high recurrence after you transplant them, but I think that's the best option for them.
It's scary to give you local regional therapy when you have 5 lesions and you already have a clot in the left portal vein.
Right. So,
Don't you have a report of the surgery, of the previous surgery before?
yes. What would you look for there?
A report of the surgery of he was resected.
Yes.
Do you have the
Yes. It was, yes. Yes. Yeah. So I'm gonna stop because we're gonna run out of time. So what happened? I don't know the end of the story. What happened was that we presented him at our selection conference again, and all of this discussion came out, and except that we didn't feel that strongly that we needed to do a biopsy. We were convinced that these are HCCs. If you go by the book, you can't have Milan criteria. None of these, he doesn't meet Milan criteria, not because he has 2 big lesions, but 2 small lesions, right? So anything less than 1 centimeter doesn't count. So if 3 of these, or 2 of these grow greater than 1 centimeter in diameter, then he is within Milan criteria, as long as the other 2 or 3 are smaller than 1, right? So technically, we can list him and get him the exception points, but is that the right thing to do? And that was what we debated about, because this is likely a badly behaving tumor, and this will be like the whack-a-mole thing. You treat things that you can treat, and you knock that down, and then the other thing will grow, and you got that under control, and the other things will grow. This will be a difficult challenge, and people felt that this was not a great candidate. So, as an advocate for the patient, I said, let's accept him, no exception point, but I'll do my best with local regional therapy to keep him under control. So we agreed that once we gave him local regional therapy, and we'll watch him for a year, and if he's still within Milan criteria, we will transplant him. So we will give him a year of observation to see how his tumor biology behaves. And then we have time to determine.
Can I make a comment?
Yes.
One thing is the patient that is not within Milan criteria, a new patient. But in this patient, I mean, he's already had a tumor, which was a big tumor. And now he has recurrence. I mean, do you proceed like from 0? I mean, do you ignore that he already had a big lesion that was taken off? to consider whether he is within Milan criteria right now? I think that's difficult.
That's the penalty you pay for resecting.
Right.
Yeah.
If you resect, you don't go back to where you
To
were
the
before.
previous stage.
Right.
Within the rules.
Yeah.
So you have to, you know, for this particular patient,
Yes.
I mean, again, I agree 100% with what you're doing, because I would watch this guy very carefully. I think my radiologist would be a little reluctant to treat disease that they can't confirm, but I mean, you can make the argument that you probably already had this disease, or that this was disease that was already in the liver. Yeah, yeah, so.
My only concern for waiting
Yeah.
is the biology of this tumor and the chances that 5 lesions today measuring less than 1 will soon be more than
Right.
1.
But obviously, the other concern is if you jump ahead and try to get him a liver quickly, then, you know, the bad behavior will not change and the recurrence will occur.
I think that's the right thing to do for the wrong reason for the patient. I mean, in
Yeah.
other words, if the patient manifests himself as rapidly growing patient with a lot of tumor burden, then you don't transplant the guy and you tell him, look, I'm sorry, we failed you in this situation. But to transplant this guy in a hurry makes me a little worried
Yeah,
that you're just
if-
going to have
If we had all
recurrence
the
in the new
livers
guy.
to transplant.
Sorry,
He doesn't have a living related. So I'm going to wrap up our discussion. I don't believe in the DAA causing aggressive recurrence theory put forth by the Barcelona group that we talked about yesterday. But this is a situation where a case like this will make people believe that the DAA therapy did this. And no, I agree, it didn't. But on the surface, if you don't know the deep history that he has a lymphovascular invasion, he was likely to set up to have rapid recurrence, on the surface, he will be counted as an example where DAA therapy caused bad recurrence. Just a comment that could be the case. All right, do you have more cases or?
So I guess we're pretty much done for this module. Sorry, Mauricio, if you'd like to still take some questions. I thought we were going to have time to. Does anybody have any question for Mauricio's talk? If you don't, as usual. Well, I guess we are done with the course, and I am very grateful to you all because the enthusiasm which have been shown in these discussions and questions and answers, and this free environment that our guest professors has given, I think it all inspired to be a real master's course. And for that reason, I am very happy, and I'd like to thank you all. Maru and myself would be very grateful if you take some time to have the evaluation sheets filled up, because it is very important for the association to show what your impression was with these new sort of courses that we are implementing. So, René, I wonder if you'd like to give some final talk, words?
Pues nada más, una vez más, gracias por haber venido. Estamos realmente muy agradecidos a los profesores internacionales que vinieron. Mauricio, Hugo, Rey, muchísimas gracias por apoyarnos. Realmente creo que esta ha sido una experiencia diferente para todos nosotros. Les agradecemos mucho todo esto. Muchas gracias.
I am really grateful for this opportunity because when I attended Train the Trainers, organized by the World Gastroenterology Organization, one of the missions that they gave us is that we should well, continue with this change. So I'm really grateful for being able to do this. It was a great experience. Arturo, thank you very much. Rene, thank you. And I hope we can replicate this again.